Junior fellows on ITU at the minute. We brought this case report forward because basically it stumped some of our team, and when we looked into it a bit further, we realised it was stumping a few more people as well. So essentially, we're going to talk about this unexplained metabolic acidosis that one of our registrars saw on the wards. Talk to you a little bit about the offending drugs, talk about this euglycemic DKA and why it can be a bit of a diagnostic challenge, and then summarise just some of the things that we've looked at and going to do from there. So this was a 60-year-old lady that one of the registrars was called to see on the wards because they just looked rubbish and nobody could quite work out why. They had a severe metabolic acidosis on their blood gas from one of the ward doctors. Again, no idea why. Background was ischemic cardiomyopathy, hypertension, and type 2 diabetes, which turns out to be relevant. They'd had a elective CABG about 2 months ago, and whilst initially they were okay, extubated and discharged to the ward the next day. They'd been in and out of hospital since, with multiple trips to ITU for leg wound infections, needing antibiotics, not really doing fantastically. When one of our team went to see them, they just looked rubbish. Again, couldn't work out why. But the blood gas was pretty bad. A severe acidosis, unable to compensate. But you'll notice that the lactate wasn't overly dramatic and never really went higher than that. And the glucose was normal. So they didn't know what was going on, but felt this patient was bad and needed to come to ITU for further assessment. And we still couldn't work out what was going on. Spoke to the renal team who wanted all kinds of weird and wonderful tests. Nothing that really flagged up though. And eventually someone was looking through the drugs and noticed that they were on, as well as metformin and empagliflozin. They hadn't heard of that, didn't really know what it was. And when we looked into it, we saw this MHRA Alert about euglycemic DKA. We checked for ketones, turns out they had them, so we'd cracked the case and started them on some DKA protocol, and basically they didn't really need anything else after that. After a few days they were back to the wards, and then a few days later they were home. So why did we think this might be worth talking about? Is because when we looked into it, and when we spoke to some of the other doctors, some of the other pharmacists, and even some of the diabetes team, and looked at kind of PubMed, we saw that there were a lot of more and more recent reports about this euglycemic DKA, and that almost every one of them mentions that people were missing it and that there was a diagnostic challenge. The new drugs, which essentially work by peeing out all your glucose, they're more and more popular because they've got these cardiovascular benefits which are relevant for particularly for our current team. They cause weight loss and decrease your blood pressure by diuresis. And they're now the second line for type 2 diabetes. But they've got a dark side. So by decreasing your blood sugar, they decrease insulin secretion, increase glucagon secretion, which is fine until you've got this acute illness or surgical stress, and things amplify, get worse. You get more and more lipolysis, ketogenesis, you end up with this ketoacidosis. But you might not see it because you've got, from one point of view, you're peeing out all your glucose. So if you look at the blood gas or you do blood sugar levels, you will have a normal blood glucose. Then if you want to check for ketones, if you don't have a ketone meter, or like UHL, you change all your ketone meters at one point and nobody knows how to use the new ones, you can't even check for those in the urine because the nephrons reabsorb the ketones. So you've got two elements here where it's difficult to diagnose this. There's been recent, or reasonably recent, MHRA and EMA guidance about this because there's this atypical presentation and you can get these really, really severe, life-threatening and fatal cases which people just can't quite put their fingers on and people are missing. So we've got these new drugs which have good uses and they're beneficial from a cardiovascular point of view, but they've got this rare reaction which can be severe and even life-threatening. We've seen a knowledge gap, speaking to other doctors, pharmacists, diabetic team, and we actually had recently had another case of this where they just hadn't picked it up. Luckily, they'd kind of been on the treatment anyway and the patient was okay, but nobody had thought to check for ketones, so it was even on the same unit, a misdiagnosis. So what do we need to do? So if you've got a patient who's on an SGLT2 inhibitor and they're acutely unwell, or they've got these weird non-specific symptoms that are rumbling on, like nausea, vomiting, weight loss, or they've just got this massive unexplained metabolic acidosis, then check for ketones using a ketone meter, not ketone in the urine, and start them on the DKA protocol. The MHRA has said that these drugs should be stopped in acutely unwell patients and patients about to undergo major surgery. We're not seeing that, so patients are coming to ITU and still on these drugs, or in hospital and really sick and they're still on these drugs. Or they're having these major surgeries and they're being started almost immediately as soon as the patient's eating and drinking. So the plan is to try and fill this knowledge gap, so talking to wonderful smart people like yourselves, talking to the pre-assessment clinics, targeting particularly the ones where there's major surgeries, where these patients are going to need a lot of care post-op and on ITU. That is essentially it. Any questions?